good morning. I'll call this meeting to order. It's 9:01, and today we're examining witnesses from the Department of Health on the Patient Access Registry. For the record, we have two members who are stuck on the bridge on the other side in Dartmouth. Becky Kent, the member from Cole Harbour Eastern Passage, will be joining us today, and Clary McKinnon from Pictou East, and so they should be arriving shortly, but we don't want to delay the proceedings any longer, and we'll start with introductions. Maybe we'll start with our witnesses today.
Good morning, I'm Paul English. I'm the Chief of Program Standards and Quality at the Department of Health. Yeah.
Hi.
Go to one. The mic is on.
My name is Lindsay McVicker, and I'm the Acting Director of the Wait Time Improvement Section at the Department of Health.
Darlene Henry, Committee Clerk.
Linda Penny?
Yeah. Linda Penny, Chief Financial Officer, Department of Health.
Sorry, Darlene.
Evangeline Coleman-Sad, Assistant Auditor General.
Mr. Epstein?
Good morning, Howard Epstein, MLA for Halifax, Chebucto.
Matt Wynot, MLA, Hammonds Plains, Upper Sackville.
Diana Whalen, MLA for Halifax, Clayton Park.
Keith Caldwell, MLA, Preston.
Chris Antoine, MLA, Argyle.
Chuck Porter, MLA, Hants West.
Well, thank you very much, and welcome. And we'll start with a brief presentation. I should say I'm in the chair this morning because the member for Clayton Park will be leading the questions for her caucus.
Good morning, committee members. First of all, we want to thank you very much for the opportunity to share with you this morning information about an innovative wait times initiative that the Department of Health has been working on for a number of years now. We've taken a major step forward in knowing how long Nova Scotians are waiting for surgery and where they're waiting for surgery. As part of Better Health for Families, I'm happy to report that we have built with the districts a provincial-wide information system that contains a centralized list of all patients waiting for surgery in Nova Scotia, and that's the first time that we've had that information in this province. The Patient Access Registry Nova Scotia, colloquially known as PARNS, was launched this past summer throughout the healthcare system in partnership with our district health authorities and the IWK, where our surgeons perform the surgeries. The Patient Access Registry system can gather and report information on how many patients are waiting for surgery, how long they've been waiting for surgery, and by next summer, we'll be able to report publicly on wait times for surgery using that as our source of data. So this morning I'll share with you how we got to where we are and what the future holds for patients and their surgeons as we strive to improve wait times for Nova Scotians. We thought we'd begin by telling a story of how we've arrived at this point. So prior to this project being initiated, surgery wait lists were managed using a variety of approaches. Many surgeons, most surgeons, had their own personal methods for prioritizing patients. It was not uncommon for surgeons to work from their wait lists in their office drawers at each site. So there was no one list, they were scattered throughout the province. So this traditional approach lacked a fundamental component. Without a centralized wait list registry, there was no way to measure how long a person had been waiting, whether they were being helped within a certain target based on their condition, or how they were being prioritized for that surgery. In the past, our wait time reporting was limited to a historical view of the wait time situation for surgeries. We knew that by working with the health districts and the surgeons to create a patient registry, we could improve the management of these wait lists. And that's the goal of this project, is to help us improve the management of wait lists and thereby having a better outcomes. In order for this to happen, it was essential for us to collaborate with our providers in the healthcare system, starting with the surgeons themselves. Over the 18 months, there were many challenges to overcome. There was a lot of people to get in a room, a lot of people to have come to agreement and consensus on how things were going to go forward. But through strategic planning and communication, we've been able to bring this province-wide network to fruition. Gaining surgeon participation to adopt the changes in practice took time, but it was absolutely essential. And I want to take this opportunity to thank the many clinicians who helped change the practice for patient prioritization in operating room booking. To accomplish this goal, we created the Nova Scotia Surgical Care Network. And this is a provincial group that includes surgeon chiefs and senior clinical leaders from each health district, the IWK, and people from the Department of Health. This group met monthly through the process, and we relied on their expertise to identify issues that we could then work through. They also helped develop supporting policies as we went along, so policies that would guide how the system would be used. We also formed surgeon working groups for each of the 12 surgical specialties to develop clinical prioritization tools and determine the minimum and maximum wait time ranges for every surgical procedure performed in Nova Scotia. We also created the Operating Room Management Standards Group. This group was established with provincial representation to lead the standardization and implementation of an information system that would help us collect the data that we needed. All of this good work needed a reliable, dependable operating room information system. Thousands of operating room procedure codes had to be mapped to a standardized provincial procedure list to ensure consistency across the province for accurate reporting. And collaboration and consultation were absolutely key to the success of this. We received positive feedback from our stakeholders in healthcare who indicated that the project team had brought the right people together to make the decisions on the operating room standards from a provincial perspective. We also hired individuals to look at the system on behalf of the patients who are on a wait list. There are now access managers in all districts who meet every month from across the province to discuss common challenges and standardized approaches to the patient access registry, administration, quality assurance, reporting, communication, and the monitoring of policies and procedures. And this is a new role that's been introduced into the system. But before the patient access registry was launched in each district, we needed to know if the old waitlist surgeons were working from were accurate. And this had never been done before. As I said, waitlists were in desk drawers. People worked with them as best they could. And our frontline partners through this process telephoned 14,212 patients to see if they were still waiting for surgery. That was to validate the list. Almost half of those people were waiting for orthopedic surgery, which wasn't a surprise to us because, as we all know, the orthopedic wait times in Nova Scotia are indeed long. But it did give us valuable insight as to where they were and if they were still validly on the wait list. And in fact, we found that approximately 27% of the people could be removed from the wait list for many reasons. In most cases, their names were already on the list, still on the list, but they had already had surgery or no longer required the procedure. So in going through that process and validating the list, about 27% of the people actually came off. We needed to ensure that the data was reliable. We worked with our IT departments in all 9 district health authorities to make sure that the new information processes worked for users and to ensure that the data passing into the system was accurate. And finally, before we went live with the system, we needed major change management resources dedicated to bringing this system in. This is a change in practice. It is a different way of doing things for the providers in Nova Scotia. And you can't just turn on a switch and say, okay, it's different now. You have to give them support through that process. And so a staggered district implementation approach allowed for improvement as we went along. So let me share some of the lessons learned from the project. This has been considered one of the most successful projects across Canada that address this issue. Our funders, Canada Health Infoway and Health Canada, who have a view of what's going on in the country, have told us that. They're very pleased with how it went, and our evaluation also indicated that. We know that there are centralized registries containing surgery wait lists in place in several provinces. Saskatchewan, British Columbia, Ontario, and New Brunswick already have them. And we worked with our partners in these provinces, in particular New Brunswick, to learn from them before we implemented ours as well. This was completed within budget. In fact, it was within 1% of budget, but we didn't go over. And the funding was jointly provided by Health Canada, Canada Health Infoway, and the Nova Scotia Department of Health. And all of this effort was done for the patient. By having waitlist access managers in the hospital, patients will have much more specific information about when they're more likely to have surgery. We know that patients waiting in the dark for a phone call for a surgery date has been a frustrating experience for people and can cause them great anxiety. People can't plan their lives wondering when the call date for surgery is going to come. And so the Patient Access Registry service and the access managers, when they're up to their full capacity, will be able to give them a very pertinent source of information that will improve communications with patients. And by increasing the ability of the healthcare system to manage surgical resources and wait lists, we can provide better quality care. Having this reliable source of information will also allow us to report on wait times and wait lists by patient urgency category. We can see if patients are receiving their surgeries within a clinically acceptable time frame based on the urgency for a particular procedure. So ensuring that wait times are appropriate as per the urgency of the surgery needed. We will maintain a confidential record of when patients were entered into the system, when their surgery was booked, and if it was canceled or delayed for any reason. If we know their surgical journey through the system, then we know where and how to improve it. We are currently in the process of validating the data with the DHAs in preparation for use in the new year. Detailed reports will be made available to individual surgeons, including their patients' wait time information, to help them better manage their wait times. And as well, the DHAs will have access to that information so that they can better manage their operating room resources. We're targeting June of 2012 to report some of this data on our wait times website as part of our transparent approach to wait times. For example, June 2011, what did I say? I said 12? I'm sorry, it was June 2011. I skipped a year. For example, we know that the number of days a patient waits for a hip replacement at a specific district health authority, similar to the diagnostic information we're already posting on our website. In conclusion, I want to thank you for this opportunity to talk about this project, and our staff is now open to answering your question on the project and how it went. Thank you.
Well, thank you very much, Ms. McVicker. Before I call on Diana Whalen, the member from Clayton Park, I want to say how delighted we are to have Becky Kent, the member from Cole Harbour, Eastern Pastures Bay, back here, safe and sound in the relatively calm confines of the Public Accounts Committee. Welcome back, Ms. Kent. And also the member from Pictou East has now joined us. We're happy to see you, but you're often enough that we don't miss you. Mr. McKinnon's here. Thank you very much. Well, it's we'll call it 9:14, and I'll hand it over to Ms. Whalen.
Thank you very much, and I'd like to welcome you all here today. I know that the Deputy Minister said he was unavailable, and it was very good that you were able to come and discuss this with us this morning by yourselves. He spends a lot of time here, so I think he probably was happy to have a week off. I was interested in your opening statement. It certainly gave a lot of good background. I really appreciate that, Ms. English. But certainly we have some questions. One interesting thing with this topic really is that this is a system that's very, very new. I mean, we're just at the point of having all the DHAs adopting it. I think July was the last of the DHAs that began to put this information, I guess, online for internal use. And I think it's important that we recognize that right now the information is being used internally and is not available to the public. So I think that is important for anybody who's watching and interested in wait times to know that this is a tool for, right now, for management to be improving systems. So I did want to sort of make that point. And also our committee often looks at the history of a project, and that's really our focus generally, and how well it's gone financially and how many resources have been used. And when I started to read the background on this, I thought there isn't a lot of history on it because, you know, we've really just brought it to the point where it's now operational. So, you know, I do have some questions about where it's at and perhaps the challenges and the costs that were involved up to this point to sort of get us started. You went through a few of the challenges, but I wanted to know if there were any unique challenges in Nova Scotia that happened during the implementation.
I think that the challenges that we had were commonly experienced by other provinces in that, again, it was a change of practice. And so you were bringing together people who had not used a provincial registry before, folks that had been managing their own wait lists. And so again, that's the big change in practice. And so I don't think that it was unique. I think that others experienced before. I'll refer to Lindsay, who worked very closely with the providers during this process, to see if she has anything to add to that.
Ms. McVicker, yeah.
Thank you, Paula. That's a great question. And echoing where Paula started was this was a change management project. You know, we look at the detail, we look what we implemented, and we're seeing one IT system going in for a provincial registry. We're seeing Meditech operating room information system being put into 7 districts, and really what this really was a people project. We try and talk about this. It's not IT. It's not IT. It's about people. It's about change. It's about what this means at the district level for the clinicians who are receiving information and using this information to better manage their wait lists, but also for the other folks in the districts who actually have to learn how to use new systems, who have to learn new booking practices. So really the biggest amount of work we had to put in here was working side by side, meeting individually with impacted stakeholders across the province in each district to understand what the change meant. And each district is unique because each district has, you know, slightly different practices around booking and slightly different practices for managing their operating rooms. And the change is always different depending on the user. One district went from a paper-based system to an electronic system. So in that district, one of the biggest challenges was getting folks who worked in the booking office accustomed and climatized to using a new system. So it was really taking the time over an 18-month to 2-year implementation to really be diligent with our communication and stakeholder engagement.
Okay, very good, thank you. I wanted to ask you about the timeline. You just mentioned 18 months to 2 years. We understand that New Brunswick had their registry implemented in 2007. Could perhaps, Ms. English, you could tell me, did both our provinces get the funding at the same time, and did we begin the project at the same time?
No, I believe New Brunswick's funding was before ours. They had implemented the project before we did.
Okay.
Ms. McVicker? Yep.
McVicker. Thank you. That's a great question as well. New Brunswick was actually up and running for approximately a year at the time when we were starting.
Okay.
And so now they've been up and running for between 2 and 3 years, and I don't have exact information on their go-live dates. Yeah. The benefit to us was that they had not only lessons learned from an implementation perspective, but they had been up and running for long enough so that by the time we were implementing, we had the opportunity to see some of the positive changes that these kind of registries can bring to a province of managing wait lists. So we were very fortunate in being able to leverage the lessons learned there in terms of how to communicate with stakeholders, what are some of the issues we're going to be facing, and what are some of the things we can hope to see after it was implemented.
So it definitely sounds like you conferred with them as you began the project here in Nova Scotia, and I think that's important to look at our neighbors and see what they've done. They seem to have gone, it says, the information I had said that it was implemented in 07 and operational in 08. Were they able to develop it faster, as far as you know, than we were? Because it seems like we've worked on it now for, 2 full years.
Well, to my understanding, I don't have a lot of detailed information on their timelines. What I do know is that we were able to learn what worked for them, but also what didn't work. And we started from their lessons learned in terms of change management, and we actually developed a more comprehensive, slightly more detailed stakeholder engagement approach. And it did take a bit more time for us, but what we're seeing in Nova Scotia is that one example is that we introduced new clinical prioritization tools for surgeons, and we see 100% compliance across the province using those, and we attribute that entirely to the success of the project team working with the leadership in the districts and the great leadership provided. Whereas in New Brunswick, they didn't see that kind of compliance on day one. It was a little bit more of an iterative process after go live.
Can I just ask, when you talk about clinical prioritization tools, sometimes you might lose us. So I'm just wondering, are you talking about almost the checklist chart that I think was in your PowerPoint presentation we were given?
You're right.
There was one there so everybody uses the same chart in answering the questions about the severity of the, I guess, the condition that the patient's in?
Absolutely. To be a little more specific, we developed 12 specialty-specific tools. So a cardiac surgeon would fill out a different tool than a general surgeon. But all general surgeons will fill out the same standardized tool as per the clinical severity and context and situation for each individual patient, and is submitted as a required element of the booking package.
Okay. I wonder if I could ask Ms. English if it was the same company. I believe it was the same company that did both of our systems, New Brunswick and Nova Scotia?
It was. The software is the same software that was used in both provinces, yes.
Mm-hmm. I'm not sure how we say that company name. Is it Acreon?
Acreon.
Acreon is it. Okay. And when it comes to the maintenance of the system, will they be maintaining our system?
The maintenance of the system, we have a maintenance contract with Acreon to continue on with that, and as well, of course, the access managers and the patient access managers have a role to play in the use of it, but the maintenance contract is with Acreon.
So they would be the ones that ensure that everybody's doing what they're supposed to do? Would they have a hands-on?
That's more the access manager's role, correct, Lindsay? In terms of what everybody's supposed to be doing, what they're supposed to be doing, that's the access manager.
Okay, so it's more to do with the actual software, the platform on which all of this is taking place technologically.
That's right.
Okay, so is that the same thing that they do in New Brunswick, as far as you know?
I believe, yes.
Ms. McVicker? Yes?
Yes.
Yes, I guess you're working more closely with it, so I thought I'd check with you there.
He's the technical expert here.
Okay, that's good. I mean, I thought it was very interesting that we have, such a close neighbor that's actually been doing this. I wanted to just go back to your opening statement, if I could, for a second, because where you end in this sounds like there's a lot we're not doing yet, because you're using the future tense. Mm-hmm. And I would like to kind of get to what it is we're not doing. We've set up the platform. Mm-hmm. We've got working groups of surgeons that have agreed to dramatically change the way they dealt with their individual patients, because they used to have control of it themselves by just keeping their own list. So there's been a cultural change there. But what is it we're going to do? Because just the second last page, I think you said having this reliable source of information will allow us to report on wait times. Now, when and how is this going to happen? How far away are we from some more accurate information and some changes?
Okay, there are a number of things that are happening right now. Number one is, before we can use information at any level to make decisions or to report publicly, we need to make sure that the information is in fact valid, that there's integrity to the data, that it makes sense, that people are doing the forms correctly. And so we've agreed across the province that, given that the last folks only came onto the system in July, that we would work through the fall and winter on the validation of that data. That doesn't mean that districts aren't internally using the information now to make some decisions. So we know, for example, that Capital Health, who's been on the system for some months, is taking the PAR-NS information, the Patient Access Registry information, and using it to allocate operating room resources. The people who came on in July are likely not using the information in that way yet. And so there isn't universal use there. Similarly, when it comes to the province using the information, again, we've said through the fall and the winter to make sure that the data is valid before we use it to start monitoring and making decisions and going back and questioning the districts as to how things are being done. So there's two ways. The districts themselves will be able to use the information for allocation of resources, and we at the Department of Health will be able to monitor and to be able to say, how's this going? We see some changes in that we'd like to see happening, and how are we going to negotiate that? And so that will happen. We see the
Can I just ask you about how we can drill down to the benefits of this system?
Sure.
We're talking in a general sense that there will be benefits and more efficiencies, but how are we actually going to be able to have more of the operating rooms, effectively used and better booked? Is that the key to this?
That's the key to this. There are two things that are key to this. Knowing that patients are getting, to be able to look at how patients are being managed from an urgency point of view. Are the patients with the most urgent needs getting their operations first? We'll have information, the districts will have information to ensure that that happens. It is the district's responsibility to manage their operating rooms. That's within their realm, so they have to do that, but now they'll have the information to do that.
Okay, so those two parts.
So those two things. The other piece is that that hasn't happened yet is that the access registry managers that are in the districts, some of them, again, I think the last one was hired over the summer, they are still learning to work the system, working with the information, working with teams around the information. Some of the next steps are going to be for the access managers to actually have contact with patients and to be able to liaise with patients around wait times. That part has not yet been implemented and still getting worked through.
I'd like to ask you some about the financial costs of the whole process and the amount that was paid by the two levels of government, I guess two different federal programs. I had printed that one page, so I'm sort of looking for it, but it is your final figure oh, here it is. Your final figure was over 11 million. It's almost $12 million.
11.9, yes.
It's 11.9. In your opening statement, you said you were within 1%. I guess, is that the 1%, 1 million on 10 million? That sounds so, no, that's 10%.
Yeah, no, the budget for the
Let's do our
project
math.
is actually 11.9. What I said in the opening statement is that the budget was 11.4, and what we frankly noticed this morning was, as we were looking at the two pages, one of the pieces that wasn't included in the 11.4 was money that was spent even prior to the projects getting up and running in terms of doing the proposals, doing the work that went into gathering the information, and when our finance people were going back and looking at all the money spent, that was money pre the money coming from the federal government, and so that's the difference. But the budget, it was completed within budget. So am I looking at the right things?
In the government's press releases, they'd always said $11 million. I looked at a number of press releases in our package, so that's where I come up with $1 million over budget. Ms. Penny?
Ms. Penny?
11.4 has been the budget of the project, and as Ms. English just said, there was a lot of work gone into developing the proposals for Health Canada and Canada Health Infoway, as well as some preliminary scoping work before the project. So while we included it in our total costs, those aren't specifically project costs. So that's the difference between the two numbers.
Well, when I look at these actual expenditures, it starts in 2007, which, you know, fully 3 years ago, April 2007, but you do have Health Canada money flowing in at that point, $440,000, so it wasn't prior to your receiving any federal money. And it, you know, it doesn't look like it's, there might be project management and setup costs, but you're actually talking about hardware costs as well. I guess your pre and post implementation cost is the line that you're talking about, the developing the proposals and getting ready to go. But it seems to have happened in that same 6-month period, or I guess 1 year period to the end of March 08. So, you know, it's surprising that wasn't included in the first go-round, I guess, is what I'm proposing. And also that more recent press releases, even 2009, were still referring to it as an $11 million project. You know, because usually government wouldn't want to underestimate a budget. If the budget's 11.5, you want to say it's 11.5 because you don't want to later be said, have it said you went over budget. So you wouldn't want to, you know, decrease that amount. So I'm still a little confused why they would have been referring to it as 11 million.
Yeah, and I guess the breakdown, the total breakdown of the project from looking at the funding, the funders, we have 5.8 million from Health Canada, we've got 3.4 million from Canada Health Infoway, and we've got 2.2 from the Department of Health. And the breakdown of the 2.2 is for the Health Canada funding, Department of Health had to provide $1 million, and the CIHI funding, we had to provide 25%, which was 1.2 million. So we do come up with 11.4. I'm just wondering if it's possibly rounding, but I would have to go back through those press releases to determine.
In the forecasted column, the final column in that financial summary, it actually says 2.7 million from the Department of Health.
And that which, okay, just which includes that additional 500,000 for the other work that went on.
The initial work.
Yes.
Ms. Whalen, I'm wondering if you could just put that in the form of a request for clarification and then we can get an answer back.
That is a good idea because we perhaps could go back and forth a bit with it. But if you could break it down because it's not clear in the financial information we've been given. Let me just go on then. So we've had some discussion. I guess I'll look for a clarification on whether or not the project was over budget more than 1%. And again, starting from its initial year of 2007. And now let me just see here. I've already mentioned the $11 million. So I would like to know if the ongoing costs now are 100% covered by the province.
I'll answer that, I guess.
Yeah. Yes. Yes.
Entirely. So that we'll have no more federal help from this at all.
No.
I know that we're talking about wait times here and managing of wait times. Earlier in 2004, we had, I think it was 2004 or 5, something like $5 or $6 million provided, I think it was perhaps even more, by the federal government for Nova Scotia to start tackling wait times. Can you just in the last few minutes left in my round give me an idea what we accomplished with that money?
9:34.
I'll start, and then if I have to refer to Lindsay, I will. So there were a number of wait time projects that we put under an acronym of WINS Nova Scotia, so Wait Time Improvement in Nova Scotia. And there were 3 projects, of which this surgical piece was one. So the PARNS was one of the projects. We had one on radio oncology, so looking at radiotherapy for oncology patients. And what's happening in that project right now is that there are new LINAC machines, linear accelerator machines, that help provide radiotherapy to patients with cancer. That's part of the project. And then the other was around looking at a diagnostic imaging pilot project with GPs around referral, if that's what you're referring to.
Yeah. Well, it is really, and I guess just for my final minute or two that I've got, I think a question for us to look at, and, you know, I appreciate the work that's going on here and that it's laying the groundwork for improvements in wait times. You know, my concern is that even in the summer, the most recent wait times report shows us dead last in terms of the wait times for orthopedic, hip and knee, very far back on cataract surgeries. You know, we don't seem to have improved. And I think it's important that here, you know, at the legislature that we ask those questions. We've seemed to have been investing. We've got these better systems, but the improvements aren't there yet.
Well, I think that what has to be recognized is in those were particular projects. So the radio-oncology project is meant to improve and enhance wait times for people waiting for radiotherapy. So that was very particular to that. As we've talked about today, this PARNS system is just going into place. It's a brand new system, and what we've seen from New Brunswick, for example, once they really got I'll say good at using that system, is they have in fact seen wait times improvement by using that information. And then, of course, the other project was different. So the projects were very targeted. We've been working with the district health authorities and Capital Health in particular around their methodologies for really breaking down and looking at what are their issues around orthopedic surgery. We're hearing from them that they're starting to see some improvements, starting to bring it down just a little bit. It is acknowledged that wait times for orthopedic surgery is an issue, and we will be continuing to work with the districts on that.
Thanks. I just have one quick question, if I could, because there's only seconds left, and that is, when you checked with all 14,000 people whose names were on the wait list, and 27% no longer needed surgery, did that surprise you? That surprises me. It's such a high number that you would take off the list.
It wasn't all that they didn't need surgery, and I'll let Ms. McVicker talk to some of that, but that was the common experience in New Brunswick and other provinces too. People go on wait lists for a variety of reasons. Sometimes people work at things like weight loss and come to a place where the surgery is not needed. Some of the people had already had surgery, but yet were on somebody else's list because there is duplication. But I will refer to Ms. McVicker to see, you know, the kinds of things and why people were taken off the list.
It's a big number.
I'll let her finish the answer. Sorry, Ms. Vicker. Ms. Whalen's time has run out, but we've talked, and we'll let you continue the answer to that question.
I agree. It's one of those numbers that really makes your eyes pop. But we weren't actually overly surprised, because this is exactly what was seen in other jurisdictions in Canada when they undertook the same exercise. Some jurisdictions saw upwards of 40% reduction simply by cleaning up the queue. And while that may not have a direct impact on minimizing wait time, it certainly reduces the queue. It gives you an accurate understanding of what's in there and tells the system what the system needs to know about demand.
Okay, thank you very much.
Thank you, Ms. McVicker. We'll move to round 2. I will get it by the end of this session. I will get it the first time. We'll move to Mr. Porter for the next round of 20. It's 9:35.
Thank you, Mr. Chair. And also thank you ladies for being here this morning. I have a few questions. I just want to carry on what you started with there, Ms. McVicker, and 27% you talked about. Of the 27%, do we know if any of those patients are deceased? Is that one of the reasons? And if so, what percentage would that be?
We did everything we could to validate the calls we were going to make against any deceased registry we would have in the hospital. Of course, the data we have access to would be hospital data, so anyone who would have maybe passed away at home would maybe not make it into the same information systems that we would have access to at the hospital level. But making those calls, it was 1%.
1%.
If that, yeah. I would have to, I can go check and validate that number.
The reason I'm asking is it's an interesting world we now live in, and I have a lot of years in healthcare prior to this career, and I know a little something about all of this. And I read this almost, and I talk to people every day. I take calls every day, and I hear stories about wait times. I hear stories about access issues, and we're going to cover those this morning. But more importantly, people seem to be of the same frame of mind, though. This wonderful technology is more of a hazard than it is a help in a lot of ways. It seems to slow things down. We spend millions of dollars, as we've just referred to, in developing what should be wonderful programs and easy access for everybody and a wait list and queues, but yet we don't have a program up and running yet that's, you know, key from what I can see. But people are still out there with their wait times, you know, and I'm going to give you a story, and I'll start it right now. I'll give you the example from a call I had last night, and I asked permission from Gloria to use her name. Gloria Fogarty had an injury to her shoulder in July. She's told, okay, in December 31st, you can come for an ultrasound, and maybe in a year's time, you'll get a surgery. You can appreciate her being less enthusiastic about all of this, given the knowledge of money being spent on these wonderful programs to help process wait times, get you through quicker, and prioritize. More importantly, when I asked the question, well, how come so long? Well, they don't do them in Windsor anymore, and they don't do them in Kemptville. Everything's got to go to Cobequid. How is that an efficiency by way of tracking anything? We spend a lot of money and time, again, on this wonderful technology whereby we're supposed to be helping to speed up the system. But in fact, it almost appears we're going the other way, and I'd look forward to your comments on that.
Ms. English?
I think that to say that the technology is slowing down the system isn't doing a service to the technology. This is technology that is going to help us bring everything together in a registry so that we can actually measure things. And so it's new technology. We have to give it a chance. It can't fix things that are happening last week, but what we really hope to do is have this information bring us to the future. That is not to say that there still aren't things to do within the system, but we need the information to be able to help the districts be able to move forward and make different changes. And so do we have wait time issues? Absolutely. I think we all recognize that, and we're building the system to be able to help people and surgeons and everybody else make decisions about that. We still have issues, and they go beyond a list. They go beyond management of resources and location of resources and all those kinds of things. But putting in Paraness is a building block to be able to make those decisions appropriately.
And I appreciate that, I really do. I guess from Gloria's perspective, though, you know, all she sees in is an extended wait time and knows all this money is being spent. And in your words, Ms. English, are going to help us.
Yep.
The key question out there is going to help us when? Yeah, you've thrown a date at us today of 2012, corrected by 2011.
2011, that was my mistake.
That is a wonderful thing as well, a year saving right there. That's how I look at that. That's all good. But what I'm saying is this has been going on for some time. I mean, I've been around government now in this legislature for 4 years and more, and we're still hearing the same thing. And regardless of who's in government, it seems to be the same thing. And I'm not being critical of anyone, just that technology is a never-ending. It's always on the edge. You're always changing something. I don't know how many of these meetings I've sat through and talked about SAP program. SAP isn't even from, I call it a disaster because that, from the appearance of me and everyone else that I talk to, that's what it is. Things aren't working. There are access issues. Now, I look at two things here. You have wait time issue and you have a database access sort of system. You can type my SIN number in and you can tell anything that you want about me. Why are we getting into something so broad when everything should be in one house? I don't understand why there are so many programs, nor does anyone else. And when I talk about anyone else, I'm talking about the crowd that goes to Tim Hortons in the evening and I sit and I listen to. These are everyday Nova Scotians who have problems like shoulders, who have problems like the flu, who go to clinics. Clinics are a great thing, don't get me wrong. I think that the clinic we have in Windsor to offset the assist the hospital is a great thing. There's a lot of things that are good in the healthcare system in this province and in this country, and I'm the first to say that because we have a great system. It cost us, yes, but we have a great system and nobody goes without. We should be very thankful for that. At the same time, I come back to, you know, the everyday chat at the Tim Hortons and in my office from constituents whose concerns are, when am I going to get my knee fixed? When am I going to get this done? They don't want to hear, well, it's going to help us. They're not interested in it's going to help us. Going to help us when is what their question to me is, well, you know, and I can go back and I can give them your presentation and I can say that, you know, Miss English and Miss McVicker passed on all this wonderful information. Again, it comes back to this whole world of technology ever changing and it seems like we're never caught up. The question that I have with this is, what do I tell Ms. Fogarty? What would you tell her? about her wait time, a year out now, and the fact that we have no service in Windsor and no service in Kemptville, and we're shooting everything. Is this the direction that technology is now going to take us? You know, are all the districts on their own separate entity? And I think you said yes. It's the responsibility of the district to manage their lists, their queue. It's the same technology, the same across the province in all districts. So I know that I've thrown a lot at you there with a couple of questions.
Okay.
Take the time you need to respond, please.
I think the question is, why were there so many systems, and is there duplication? Or?
I think she's got it.
Yeah.
Okay.
What I interpret it is what difference is this going to make for people, and how do we communicate that these things are going to make a difference for people. And I guess what I'll go back to is that the opportunities that something like the Patient Access Registry of Nova Scotia gives us is not just at the district by district level. We know that when people are looking at how to allocate orthopedic, for example, orthopedic OR times, they need to have a sense of what are the needs across all the services. Are they in fact getting the people with urgent needs in most? There will always be people, because of the need for appropriate care, are going to need urgent care more than somebody else. So I think that's a fact of life, is that the best thing to do is to be able to allocate surgery time based on appropriateness and urgency. So the ParaNest system is going to be able to help us do that. And I'm saying going to be able to because it's a new system. It's just been in since July. It's been being put in for a number of years, but that's how long it takes to put it in. Along with that, there are other things happening. We have the orthopedic pre-assessment clinic, which is getting people in within just a couple of weeks to be able to see a surgeon and a team to say, okay, you know, what's happening with you? Are there things you can do while you're waiting? Or, you know, do you need to lose weight? What are the various things for active waiting? We're seeing a reduction in our wait one time, which is what we call the time from referral to the time they actually see a surgeon. That's been very beneficial. So the ParaNest system is one piece of what's been happening. There are a number of other initiatives that are happening at district levels. The benefit of going forward, sir, is that through the surgical care network, which I mentioned in the speech, that network started out as a group that was looking at ParaNest and how do we make the Patient Access Registry system go forward. It is evolving into a group that is going to be looking at surgical standards across the province, looking at things like how do we use best practice, how do we move things, how do we share information about cases. And, you know, we believe that as things evolve, you know, we'll be looking at capacity in one district versus another, and how can patients get the most appropriate care the fastest. We can't do any of that without accurate information. So does it help Gloria tomorrow? Probably not. I can't probably look at her and say this access system is going to help you get your surgery or get you into an ultrasound faster. But we're building a system to be able to go into the future in a more appropriate way.
Thank you for that. And I think all of those things that you mentioned are wonderful, they're admirable. You know, that we can share data and access that. Only the more you can share with one another makes us better as individuals and doctors and cases and all of those things. But at the same time, they do very little to help speed up the process. It'll be interesting come June of 2011 to see exactly where we are and whether or not there are any reduced times. Yeah. You mentioned a couple of other entities like oncology. We've had a recent experience there with a family member, and they have been nothing but wonderful there. And again, I've dealt with patients over the years as a medic. It's always been very good and well looked after. The people are great. And it seems like you can get in there fairly quickly. I mean, it's one of those kinds of issues, diseases that need to be looked after immediately. Would you suggest, me having said that, that there's a lesser priority for ortho patients, or a different kind of patient versus maybe the, you know, a cancer patient?
I don't want to get too much into clinical pieces here, but when people are looking at resources, it would be appropriate to say that, you know, we need to make sure that true urgent cases are looked after in a timely fashion. If cancer surgery doesn't happen within a timely fashion, the trajectory for that patient, the trajectory, pardon me, may not be very good. It's not great if people have to wait for hips and knees either, but it has a different consequence.
Right.
And so that all has to be taken into consideration when they're prioritizing
And I
things.
understand that, and the words timely fashion are very interesting that you mentioned those, and we'll talk about that as well. And I agree with what you said. Cancer patients, we know the outcomes, the timely fashions that need to be treated, and that's great that we're getting them through, or at least the bulk of them through, rather quickly for testing and results and potential treatments. At the same time, here we have Ms. Fogarty. And just as an example, now she's going to be off work a year. What does she do? You can just imagine, I think your word, part of your speech opening comments where you mentioned the words anxiety. Well, yeah, anxiety is probably putting it quite mildly, in all honesty. The stressors that will now be on her for her time away from work, financial, family, I don't have to explain all this to you, you know all these. She would probably look at that as being somewhat significant as well.
Absolutely.
So there are a variety of differences, and I know you can't compare apples, and oranges and so on, as much as we might like to try to do that across the board as a system and as a province. And we've got it broke down so bad now that we've got these districts, which I'm not sure that I favor a great deal, at least the number of districts we have, because the inconsistencies among them are some of what have bothered me over the years that I've seen. Why do we do business different in a capital than we do in Western, for example, versus Pictou County maybe, or others, And I know for a fact that there have been inconsistencies in simple things even like procurement of equipment. I never could figure that out, and I'm a bit concerned when I hear we're going to have one system, but we're going to leave it to the districts to manage it. That tells me that there are 9 different management systems that are now going to manage what is supposed to be a consistent system. Am I on the right path there, or am I wrong? Please clarify that for me.
I think that what is correct is that within the districts, the OR committees in the districts, they do allocate the resources. What this system gives us, though, and gives the Department of Health in particular, is a way of monitoring that, because we will have access to the information eventually as well, where we're able to look and say, okay, are there differences in what's happening with wait times from district to district? We will have the information and be able to question and monitor and evaluate that as well. That's one of the benefits of this system. The Surgical Care Network is going to be reviewing the data and being able to look at inconsistencies and to be able to look at things and say, if we're all working from the same basis of information and yet there are differences between districts, why is that? And how do we take best practice from one district and put it into another? And so the Surgical Care Network is meant to do that. That's one of the purposes of that. And that's a very positive thing.
Do you believe this system is going to tell you anything you don't already know? We already know that, the bulk of the people in Nova Scotia live in the Capital District. They live here in Halifax. We know that wait times maybe are longer in Halifax or shorter in some areas. We know that patients move around from the Eastern Shore and go for a surgery at Hans Community in Windsor for a knee or some minor surgery like that, and that has gone on. Is there a real benefit, I guess is what I want to come back to again, is stretching the benefit here and trying to stress the importance of that's great, we know all that. Whose decisions are going to be then to manage it? You say the departments, like the minister, the deputy, the premier, the bureaucracy.
Yeah.
I'm interested in knowing who's going to manage that once we know, and we're going to have variables. We know that. There will be variables in different districts. That can't be helped just due to demographics and populations and everything like that. So who's going to manage that?
Well, within the Department of Health, we're also have just recently undergone some reorganization to be able to look at the areas that we know need to be strengthened within the department and need to have different levels of resources. So, for example, within our Chief Information Office, we're also developing a decision support system and strengthening the system that's been there to be able to provide information to the department. Within our policy shop, we're going to have a accountability and performance and accountability system within the policy shop. And then what we've also just done is we're just hiring an executive director that will be reporting to my position of health systems, quality, safety, and wait times. So we're setting up an infrastructure to be able to take the information that's coming from a lot of sources, not just from Patient Access Registry, from CI-HI, from all the federal sources, take that information, work with the districts, enhancing accountability and manageability. Within the DHA Act, it is the District Health Authority's responsibility to deliver care. It's the Department of Health's responsibility to monitor and to evaluate and to hold accountable, and we're strengthening those resources to be able to do that. And so there will be, as I said, within the Department of Health, a health systems quality piece, and that will be managing, working with the surgical care network to make sure that the changes that need to happen. That's what I can tell you on that right now, sir.
Thank you, and I guess it comes back to the same thing. I want to go back to the Tim Hortons crowd who talk about this system and talk about healthcare in general. They have no idea what you just said. No. They're saying for certain that, okay, here I have a district who's managing my healthcare, but yet I have a province who's the overseer. So I'm a taxpayer. No wonder there's such a wait time issue, a mess up in the system. Again, I'm going to come back to the simplicity of this whole thing. It's the technology. I can generate a SIN number and pump it into a system, and the federal government can tell me all about me and then some, anything they want to know. Why do we have a variety of all these systems? Why wouldn't everything from my medical records to my, you name it, that's related to Revenue Canada, there's all one huge data bank there now. Why are we veering away from something that's not all in one house, I guess, for lack of a better word? And then the other problem is, here I have the district managing my care, and I understand that, I guess, sort of having worked that way. But they might have the Department of Health as an overseer. Who are these people in the Department of Health? Are these folks healthcare professionals? And I don't mean that in the way it sounds, forgive my ignorance, but I'm asking because I think it's important to the people. Are these doctors and nurses who are managing and overseeing what's actually going on by way of care? Because I think that the everyday Jane and Joe out there would like to know who is the overseer and stress the importance of that. That is a key issue for people. And they sit back and they say, well, you know, how does, and I'm going to use you, how does Miss English know what she's talking about if she's not a healthcare professional and hasn't worked the system and has never been there? This is what the people on the street tell me. So this is a great opportunity this morning to have you here, and I'm glad you're here. I would have loved to have the deputy as well, and all of you. You know, you've been around here and you're knowledgeable. So I look forward to the response to that question, because the people will want to know how that's going to work.
Okay. I heard two questions there. One was about the systems, and then the other is who are the people at the Department of Health. In terms of the systems, technology, as you've identified, is evolving, it's growing. We know that there are various systems throughout the province and throughout the country. It didn't grow up as one system, it grew up a piece at a time. Right. That's a fact, we know that. One of the things that a great deal of effort is being put into right now as we speak is the electronic health record. You may have seen some ads through the Globe and Mail in different places recently where they're doing a campaign saying all the information in one place. I'm not the technical expert on that. We can get more information on the electronic health record, but the electronic health record is being developed to take all the different pieces of information from the Meditech system, from this system, from the systems of Capital Health, from the PAC system, which is the diagnostic imaging, that is all going together into a system to be one electronic health record for people to be accessible wherever they are. That is in process, sir. It takes a lot of time. It does take a lot of resources, so choices have to be made about resources and what are being put to things. That's evolving. So that's the one place for information. It is coming. The other piece that, in terms of who is at the Department of Health, there are a variety of people at the Department of Health. I am a nurse by profession with a Master's of Nursing. Lindsay has a technical background and things. There are many health professionals at the Department of Health who are working with this. The folks at the Department of Health are very knowledgeable, and I'm very proud to work with them all. And it's the people at the Department of Health are a mix of professions to be able to provide a mix of services. And I guess, you know, that's what I can tell you. There are many health professionals working at the Department of Health who are knowledgeable in their background.
Thank you, and we'll come back to it in a bit.
Thanks.
Thank you, Ms. English. Well, we'll move to Ms. Kent. You've got 20 minutes. It's 9:55.
Thank you very much, Mr. Chair, and thank you very much for that lovely welcome. It certainly is nice to be back, and I can't think of a better time, I guess, in a few extra meetings to come to where I have Department of Health in the room and former paramedic in the room, and I don't see anything over my head that could potentially fall down, but if it did, I know I could be cared for, so it's a good day, but it's certainly nice to be back, and I want to certainly thank you for being here. My colleague, a member of the committee, had referenced, his own experience and one particular resident in his riding that no doubt every one of us as MLAs have stories like that. I can tell you for sure, much of the health issues that come to us are associated to wait times, and often they're just difficult stories to hear, difficult for families to manage, and so that's not news, and I know that, and I'm confident that you and your department have a sense of that. And the other thing that was suggested a few moments ago was that, that perhaps I got the sense perhaps that you're spinning your wheels, you're putting money or time into something that is not, is it going to be the most effective approach? Frankly, it's your job and it's government's job to take these steps. When you see the inadequacies that we are facing in our healthcare and our wait times that families are experiencing and people are experiencing, so to suggest that it isn't going to work or it's not the right choice, of course they can condemn that and say that's negative, but to do nothing is the opposite, and that would be unacceptable as well. So I'm pleased to see that you're making these strides, and you're not fully there yet. I think that's an important aspect to remember. You've noted it, that we don't have all of the bugs worked out. We don't have all of the end result that we can speak to today, but you are giving us a sense. And in fairness to our colleagues that have brought this up, our accountability is to our constituents that come to our office. So we look to you for ways to express and explain what you're doing to them. So at the end of the day, they can go home and they can tell a loved one what it is our government and our health department is doing to help them. And I too am still a little confused about how at the end of the day that we can explain the positive and the impact that this will have for our constituents. So I'm going to ask some more questions around that.
Sure.
I know you've probably covered off some of it already, but that's what we need to be able to do, and to tell our public what it is that's going to be a positive effect at the end of the day for them. So we have a list, and I know that makes sense, and is that list complete now? We fully have an understanding of who's on a wait list for surgery right now?
Okay, I'm going to hand this one over to Ms. McVicker because she's been working more intimately with us.
Ms. McVicker?
Thank you. We have patient access registry implemented as of July, and as Ms. English was saying earlier, we're in a process now of having the districts validate the information that they've put into the system, because flipping the switch on a system, well, there's a lot of work that goes up into it, and the big bulk of the work for clinicians and folks on the ground was taking their wait lists that existed on paper and pumping them into a new electronic system. So you need to go through, work out the bugs, work out, data accuracy. Was the data entry done appropriately? Are there errors? And then there's a second level of vetting that needs to happen at the district level, and that's really where the clinicians get a look at their wait list for the first time, and they do some integrity work on it. Like, does this look like my service? What's going on here? Is this accurate? And then vetting the information throughout the organization at the district level. So while yes, we have some preliminary information, the caveat is that there's still some validation happening at the district level, and we won't consider it complete until January 1 is the date we have agreed to with the district health authorities for having the information.
Okay, that was my last question.
Yeah.
Is there a timeline of which they have to respond? And are they responding well to this process and this development of the health authorities? Are you getting any pushback? Is that going well?
Yes, adoption has been going well. And all along, and I attribute that to 2 years of engagement leading up to it, and explaining what this means, explaining what the transition is, explaining, as we are doing today, to the folks who work in the district health authorities, what is the benefit, what are the benefits, how is this going to work for me, how is this going to change my job? I'm used to going to this piece of paper, I don't want to go to your system. Well, it's working through that kind of process about here are the benefits, here's what it offers you, the user.
But they've been fully engaged in that, so because
Absolutely.
I mean they're on the ground, right?
Yes.
They're there in front of those patients and those families every day. That's good to hear. And so let's look a little further out. let's look to 2011. So we have this list compiled, we have this report that you're working back and forth with our district health authorities, and all of a sudden you recognize that something's out of line, something is unacceptable. What kinds of, and perhaps that's not fully fleshed out yet, and so I'm not going to necessarily hold you to it 100%, but in your mind's eye, what do you envision Department of Health could do or direct a health authority to do to correct that? If in fact, because that's the end result, is that if we've come across wait times that are unacceptable after we've got everything up and running, what kinds of steps will we do to fix that and pull it back to right?
That's a great question, and I just want to pay attention to how you've described this, and we're talking about a list, and as Ms. English said earlier, huge benefit. Actually taking the lists that existed here, there, and everywhere into a centralized location for the districts and the Department of Health to access and be able to review is very positive. But there's more than the list in the system. It is a robust reporting tool for folks either at their operational level or at the provincial level. And that's really important to know. So I can give you an idea of some of the benefits we could expect to see, absolutely, particularly based on the experience that we've seen in New Brunswick. Okay. And one example of this is that there's a report in the system that will show who is waiting, but it breaks it out by different urgency levels. So patients who really should have their surgery done in a week, we'll see their wait times. Here's the 50th percentile. Here's when most are getting in. All the way out to the folks who are the more elective patients. And what we can begin to see when we look at this information, and what we've seen in New Brunswick and have had huge success in that province, is being able to see, okay, are the folks who should be getting in within 2 weeks getting in within 2 weeks? And are the folks who should be getting in within 12 months getting in within 12 months? And what they were able to do in New Brunswick is look at this information and say, whoa, our least urgent patients are actually getting in before our most urgent patients. And by taking this information and being educated and more familiar with how wait times are being allocated and how OR time is being allocated based on patient urgency, they were able to bring their wait times under 2 years, then under 18 months for the whole province. Now they're aiming for under 15 months. And that is exactly the kind of benefits we are expecting and hoping to see in Nova Scotia. Because it's not about removing wait times altogether. There'll never be a zero wait. It's about getting patients in within a clinically appropriate period of time. And that's all, and back to the piece around the question the gentleman asked earlier about, what's new? You're not seeing anything we don't know. Well, you know what? Seeing the data presented in this way is actually a fabulous step forward in terms of, there's one thing about knowing things anecdotally, and our clinicians are extremely knowledgeable about their own wait lists and what's going on in the district, but to be able to pull it together from a provincial perspective and see the information broken out by surgeon or by procedure, or we can slice and dice this data in numerous ways, but being able to see the clinically appropriate wait time periods that patients are getting in within is a huge help. And if I don't want to take up too much time, but we actually saw an interesting effect early on in one district that went live, where it showed, oh my goodness, your least urgent patients are getting in well before your most urgent patients. What's going on here? And the thing is, before the system was in place, you wouldn't have this information. You wouldn't be able to ask those kind of questions. And so the question was asked, well, what is this effect? What are we seeing? And it turned out that once the access manager was able to dig down a little bit deeper into the situation, that there was a new surgeon in this district, and that surgeon had received patients from a number of surgeons. And so the surgeon happened to have received a bunch of elective, non-urgent patients, but he was using his OR time, and it just so happened that for that reason, elective patients were getting in very quickly because it was a new surgeon. And that effect would eventually go away in that district as that surgeon's patient list changed. But the ability to ask that kind of question, to have the information at that level, and to drill down into that individual patient if we want to. Who is this outlier? Who is this person waiting 900 days, for example? And so it's a great step forward.
Thank you. And again, I'm trying, my question will be around trying to understand a little further out the ripple effect of scheduling changes and how that's communicated to our patients, because it's not, we hear some stories where someone gets in because the urgency of it, and another person might have, a 5-month out date, and then we hear of someone who gets a call and says that's changed. Inevitably, sometimes those things change. And as this system becomes, effective, which I have every reason to believe it will, what is the communication process for our patients? What do you have input into that? Ultimately, it's, this is the department's overseeing umbrella mechanism at the district health authorities. What can you do to help with that, to see that this system becomes well communicated to the patient that at the end of the day is most directly affected?
Sure. As Ms. English was saying earlier, a lot of that function in terms of communication with patients will be through the access managers, because they are put in place in each district to have that patient-level information, to be able to drill down and see an individual patient's journey. The system tracks every point the patient has on their way to surgery, whether it's cancellations, the reason why they were canceled, the fact that a patient may be in Florida 6 months of the year, all of that information, to be able to have a more detailed conversation with the patient, look at the wait list they're currently on, look at the length of the wait list, and help communicate with them on the particulars of their wait. But from a different perspective, another policy we're recommending provincially is really based around the success we had validating the wait list initially before turning the system on. And this is, we're advocating and recommending that access managers stay in touch with their long waiters. And this has worked very well in other jurisdictions in Canada, again, particularly New Brunswick, where after a year or after 18 months or whatever time period we agree is appropriate, that long waiters will be contacted, how are you doing? Are you still waiting? To ensure that the wait list is validated, but to let patients know as well that there is going to be a communication channel there. There is a role in the district that's a liaison between the clinical and administrative worlds that they can communicate with about their issues and about their waits.
Good, thank you very much. I want to switch now to the surgeons. What role did they play in helping develop where you are today? And how has the feedback come with that, as far as their embracing of it, and how does this then affect? I mean, they're one of the biggest common denominators here that's going to most affect this wait time. How does this affect them and how they do their job? And I guess before that is, what role did they play in getting to here?
Sure. I'll take that.
Ms. English?
Yes, they were instrumental in that. As we talked about, the surgical care network was set up at the beginning of this project that had all the surgical chiefs, and there were anesthesiasts there as well as there were surgical working groups that worked on the prioritization tools. And so it wasn't that we handed them a tool and said, here it is, boys. They were part of developing those tools as well. We had something to work with, but they had to make sure that that they were part of that. So they were instrumental in the introduction of the whole thing. There had to be working with changes. They had lots of questions. They had changes of practice they had to work through. And I would say that to some extent they're still working through them in some of the districts. That's still happening, but there is very good compliance to this. And so they were part of it. They came together, they had consensus, and they went forward. So absolutely the surgeons were part of it. The biggest change to their practice, I believe, is twofold. One is that they now have to do a prioritization checklist before a patient is put on a wait list. And so they would have had their own method of prioritizing, and now there is a standardized way of doing that. It doesn't mean they can't have clinical judgment, but there is a standardized way of entering people into the wait list. So they have to do that for every patient. The other piece is going to be as the information is used around the management of OR times. So they'll be involved in that. Surgeons are represented on OR committees, and there may be changes in OR times to individual surgeons. But that's going to be based on prioritization and information, and as we've all talked about, getting the most urgent patients in the queue at the right time. Lindsay, is there anything you'd like to add to that, Ms. McVicker?
Ms. McVicker?
I agree with everything you've stated. Another change for surgeons throughout this project and these new processes is that wait lists now exist in a central registry. That's a culture change and a game changer for the entire healthcare system. And that, for some clinicians, was something to get used to. It's a new concept in terms of who's able to look at wait lists and have accurate data and timely, real-time data on the wait lists. For some surgeons who were using local systems or had their own local, really good processes in their own offices, It's not to come in and say, oh, the way you were doing things was bad. It's about to come in and say, here's the provincial benefit to it. And that was working with those clinicians who had to maybe change their processes that they valued a lot to bring them up to speed with the province, or in some cases to have the whole province catch up to them.
And when you reference standardized, we're talking about a patient in Shelburne, a patient in Musquodoboit, a patient in Cape Breton, and a patient here in HRM. Can you just give me a little sense of what will change in what they're receiving now to when this is in full benefit, what that standardized process will do for them, and why is that different now?
Is Vicar?
The standardization has to do with it being a common tool being used by all surgeons within a specialty. The same questions being asked of every patient and that information all flowing together to calculate a score and a target surgery date for each patient based on how the questions are answered for these tools. So a patient in Yarmouth is going to be prioritized with the same tools a patient in Cape Breton, asked the same questions, and the score being generated the exact same way. And what this gives us is again a wait list that actually divides patients out by their urgency category, and which may not be of an obvious nature to a patient, but for the people who are responsible for scheduling and for the people who are involved in monitoring the healthcare system, it's of utmost importance. Because in the past we were able to provide wait time information as a province, but when you can't break it out by your urgency categories, it really becomes less meaningful and less valuable across the board in terms of making those improvements that we need to for patients.
Okay. We've called this a list, or is it a report? I get what I'm... the information that you've gathered, you're going to have in the department, what kinds of, what things are on that report? What information is there? And will it be published? And who would get to see that? And I guess, and how often will that happen? How often will you update this information? Is this an ongoing thing, or is it just every so many months, years?
Good question. Now there's really a twofold answer here. The first is that there are a number of reports that come out of the system. First and foremost, surgeons are going to receive their wait list, as you've been describing, that will show all of their patients based on their urgency category. Are you past your target date? Are you nearing your target date? Or are you still within a month, more than a month away from your target date? There are a host of other reports that show more aggregate level information to show how are we doing as a service, or how am I doing in general across all my patients in terms of my wait times for getting patients done, who are my outliers. When it comes to generating reports, surgeons and administrators at the district level or at the DOH can receive reports anytime they want from the system. One of the biggest benefits of putting the patient access registry in place is the accessibility of the information. This can be a big issue with information systems, being able to generate reports from it and have them readily available in a timely fashion for those who need it when they need it. And this system is in place and able to provide that. In terms of public reporting, we will be using the patient access registry as our source for surgical wait time reporting to the public in the spring. We're thinking in the June timeframe. And we will probably start with quarterly wait time reporting and refresh the data every quarter. In terms of best practices, it's really a toss-up between refreshing your information monthly to the public or refreshing it quarterly, and it's really trying to achieve that balance between timeliness of reporting versus making sure the data is as quality and as accurate as possible. So,
yeah, as you had mentioned about performance policies and accountability policies, that's an important part of it. You know, audits of the system that we have, and so that makes sense. I'm pleased to hear that there will be a rollout to that, so the public understands that, you know, at the end of the day, the evaluation of is this working, and that's an important part of course this committee, but the public should have access to this. Not everyone tunes into this lovely event every time we have these meetings, but on an ongoing basis, though, you have real-time information that's coming back and forth from the district authorities. Even though a report's not being generated, to be very clear, it doesn't mean that information is not constantly being communicated back and forth through the department through this process. Is that correct? Yeah. Okay. Audit, is that something that's
Ms.
forthcoming?
McVicker?
How often? Do we have that established?
Ms. McVicker, I was going to say that Ms. Ken's time has run out, and maybe we can come back to that in the next round, but we'll move to Ms. Whalen. It's 10:15, and you've got 13 minutes. Thank you.
Thank you very much, and I would appreciate it just if your answers can be a bit short, because our time is always, limited here at Public Accounts. I did want to ask you just once about the timeline of the introduction of this entire new system. Clearly, it seems to be a good idea. It's worked well in the 4 or 5 provinces that you've alluded to in your report. But when I asked you about the earlier wait times money that was made available from Health Canada, and that we were to address our wait times, that was, practically when I was a new member, and I've been a member 7 years. I think it was 2004, but it's been years ago. When I asked you that question, you said that they had actually at that time looked at a number of different things that you needed to do, and one of them was this patient access registry. It was recognized as a need. Can you tell me how long we've sort of been looking at it, and why it wasn't done sooner is really what I want to know. So how long have we been considering it, and what took so long?
Ms. Penny? Oh, no, sorry, Ms. English?
I just want to make sure I'm answering your question accurately. I want to make sure that the money that I referred to around the projects is the same money that you're referring to that came in 2004, because this money did not come in 2004. So I just, I'm wondering if we're talking about the same thing there.
Well, in reducing wait times, you've made the case, and the minister has in her press releases and so on, that this patient access registry is going to lead to better and more prompt service.
Yes.
And so we know at the bottom line is that we're paying almost $12 million and have paid that out. A lot of it leveraged from the federal government, thank goodness, so it's not all Nova Scotia, but still, every dollar we bring into the province, we want to see that it's got a benefit to patients.
Absolutely.
So the bottom line is better service to patients and less wait times. Again, why wasn't this done sooner? It seems to me that we needed that in order to shave down the wait times on all of the surgeries.
I guess the answer that I can best give to that, and I'll ask my colleagues if they have a different answer than that, is that the money that was available for the information systems part of things through Canada Health Infoway and Health Canada came to us at this time, to be in 2007, I believe, Linda, is when it all started. So that's when targeted money for those kinds of things came out, Ms. Whalen. The money that you're referring to in 2004, and frankly, that predates me being with the department, so I'm not 100% sure what that piece is. When money came that was available for targeted initiatives around patient registries, that's when we went forward and made sure that happened.
Now, again, we talked about this being about a 2-year project, but New Brunswick got theirs begun in 2007 and up and running in 2008. So can you give us some indication why we were slow?
Well, I guess Ms. McVicker alluded to that earlier, is that New Brunswick started out, they did their piece of work, and we learned from New Brunswick that there were some things that we needed to do in terms of incremental approach to things, of not putting everything in at the same time, of making sure that the change management was done appropriately. And so we took longer because it was indicated to take longer was better. Ms. McVicker?
Ms. McVicker?
Thank you. I'd just like to add to what Paul is saying, to point out that in Nova Scotia, we also implemented operating room information systems as part of this initiative. In New Brunswick, they either stayed with the same information systems that were on the ground already or devised a more manual approach with the patient access registry. So there was a lot of interface building between the systems that are currently in use in Nova Scotia at the operating rooms, as well as the implementation of new ones in 7 districts. And that in and of itself was a huge effort and a huge component of this. And we recognize that operating room information systems were something that districts had wanted for years, something they'd seen of great value, and we wanted to take the opportunity with this federal funding to put something in place that will be of great value to them operationally, as well as from an access reporting piece, but also for the maintenance and use of their OR time every day.
Yeah, I do understand what you're saying if you added an extra system, but I have two questions then that would follow up with that. One is, we often hear this at the legislature when we're here at Public Accounts particularly, is that we have too many different systems out there and they don't talk to each other. We've seen it in the diagnostics, you know, trying to be digital with x-rays and sending files back and forth. We've got all kinds of different systems, which is a tremendous inefficiency. Was that one of the impediments that you faced?
In this project, it was not.
It was not.
It was very clear that the Meditech system was the one that would go into the districts that required a system. And from an access registry perspective, this system, and I don't want to get into IT.
No, I don't want to either.
Our information systems sit at the district level, and they feed up to a registry that sits over all of them. So the interfaces were vertical, not
And every
horizontal.
DHA is using the same one? Meditech system is being used everywhere?
In 7 of the 10 districts in Nova Scotia.
And is Capital Health one that doesn't?
Capital Health and the Valley share a system, and the IWK uses a different version of a Meditech system.
And Capital Health being our biggest one, was that no trouble that they were using a different system?
It was no different than the Meditech system in terms of creating an interface for information to flow to a registry.
Okay. As I say, I'm not a technical IT person either, so I don't want to go into it further than that. As long as you tell me it didn't cause any trouble. I just wanted to ask a further question on the timing and the rollout. If we knew that New Brunswick and Nova Scotia got the money at essentially the same time, was it a deliberate decision internally to wait and watch New Brunswick and see what they did and whether we learned from any of their mistakes?
I believe New Brunswick was already implemented and rolled out by the time we got around to planning.
Oh, the information I have is 2007. They were implementing 2008. They began, you know, in earnest. It went live, I guess. So it would seem that it overlapped. Have you been in the position for 3 years? I'm just wondering,
In
Ms.
this particular
McVicker.
position, I have been in the wait time, involved in wait time reporting for over 3 years, yes.
Yes.
So they were nearing the end of their implementation when we were getting started in planning. I shouldn't say they were entirely up and running and live.
Yeah.
But we were able to leverage the lessons learned during that period of time.
You know, I do go back again to the timing because they seem to have been able to do it in a year, or perhaps, you know, it was within a year, at least on paper. It appears to have happened. We've seemed to have taken 3 if you look at the financial rollout of this from the early proposals to now. And we're not yet ready to make it live for the public or, you know, have reporting available because it's going to take time. I understood about the validation. So we're not really there yet until 2011, which is even longer. So, you know, I'm just wondering how we can reconcile that it took us that much longer.
Well, I can't speak in any kind of knowledge or detail to exactly what the project planning around the New Brunswick project was really about. What I can say is that it was an immense achievement in Nova Scotia to implement the number of activities, information systems, policies, process changes, get the buy-in and the support from the stakeholders that we needed to along the way. And what we've ended up with is a system that's being used. Compliance is 100% with using these new tools, and we're very fortunate to be in the position we are now.
Okay. When it does go live, I just wanted to go to the kind of reporting that New Brunswick does. One of the criticisms we've heard in Nova Scotia, and frankly, a question I had when we looked at this system when it does go live, is we do have the other websites, My Surgery, which people can look at, and the wait times information that's kept on the Department of Health website. So now we're going to have a third one, which will be this one. No? How are you going to integrate those two then? Because, as I say, it seems like we may have a proliferation of them.
Ms. English?
Yeah.
We're not going to have a third website for wait times. This information from PARNS, the Patient Access Registry, is going to be the source of truth, if you will, for the wait times website. So the level of detail of the reports that you see, those are not going to be reported publicly. Those have patient names. Those have, I mean, those are for internal use and for management. But this is the information that will populate our wait times website.
Well, then I'd like to ask about how that format on the wait times website will look, because when you look at the New Brunswick one, they show you a tremendous level of detail. They show it by facility. So I'm just looking at the first page of it that we had printed, but it'll show every one of the facilities that does surgery, and it shows it by type of surgery. You know, there's a whole list of different surgical procedures and how long people are waiting. And the other important thing is they show it by percentage and and by the actual number of people. We've been, criticizing government over the years that all we see are the percentages, and that, is quite misleading. I mean, is it 10 people and you're talking about 10%, or is it 1,000 people at 10%? Makes a huge difference. Can we look forward to seeing a level of detail that's much greater than we have currently?
I'm going to put that to Lindsay, who's
Ms.
been working.
McVicker?
We couldn't agree with more with your observations. Okay. We recently redesigned and relaunched the Nova Scotia website in preparation for the IT system that is coming in place for surgery, and to bring the Nova Scotia provincial wait time reporting website up to standard in terms of national standards and best practices for reporting wait times. We know exactly what our colleagues are reporting in the other provinces, and we admire the work that's done in other provinces and strive to get there ourselves. And what you need, of course, is a source of information that's robust and can provide the accurate and timely information we need to provide that.
So in other words, you will give us the actual number of patients, and obviously we protect privacy, we don't need to know names, but by facility, by name, not by name, but by facility, actual numbers, and by procedure. Can we look for that level of detail?
Yes, so surgical volumes is something, along with other things like trending and 90th percentile.
Because it hasn't been very robust at all. Like me, it wasn't very helpful. If you were a person like, as we talked about, an individual who's got an injury and you wanted to know where you stood, you'd have no idea how long it's going to be. And I think that's the key thing here, is that one of the things the minister has said is that you're supposed to be able to find out where you are in the queue and how long it's going to take. And that's important to people to know, so that they can plan and understand how much time they're going to have off work and so on. I think there's very little time left. I wanted to ask you about the capability of this system. So I'll just be brief, but basically, will it have the capability of letting surgeons assign a surgery to another district where there's a surgeon available? Will they be able to be involved directly, so that they could say to their patients, there's more room in another district, you can go over there?
To identify capacity in neighboring districts to potentially...
If they know the waits aren't as long.
That is something that this kind of system would absolutely be the kind of information source that could inform those kind of decisions. I don't want to play down the complexity of patients traveling for surgery, because it is significant for certain specialties, but yes, this is a kind of information source for that, to inform that kind of decision.
So the surgeon themselves could look at that information and say, I'm booked up for 3 months, but my colleague in Windsor can take you next week.
To be specific, the surgeon in one district could not go and look at the data from another district, but there's nothing stopping surgeons from having dialogue now that they have this information with each other within a specialty. And again, I want to point out what Ms. English said earlier about the surgical care network. This is exactly the kind of issue that having a provincial body that consists of chiefs of surgery and other clinical leaders and administrative leaders, together with the Department of Health, looking at the data to answer those kind of questions.
Okay. On another point, in one of the minister's press releases from September 09, she indicated that it would help make decisions where we can put healthcare dollars or healthcare resources to better use. I'm wondering if there's any move afoot to have incentive pay around performance, and the reason I ask that too is there's a reference in your PowerPoint that talks about surgeons' remuneration in semi-annual payments starting October 10, 2010, and it's not said why. It's on page 5 of the presentation. Could you relate to that? Will there be some sort of incentive pay?
Ms. English, I'm afraid that Ms. Whalen's time has run out, and if maybe the Conservative Caucus can follow up on that, but in the second round it's a little harder to allow for extra time. We'll start with Mr. Porter for the Conservative Caucus, and then we'll move to Mr. D'Entremont. I believe you have 13 minutes. It's 10:28 and a half.
Thank you, Mr. Chair. I'll take a few minutes and then I'll hand it over to Mr. D'Entremont. I want to just talk a bit where we left off. It was around resources. There's a resource issue today. There will be a resource issue tomorrow. And in June of 2011, there will still be a resource issue. What you've described to me is we'll then be able to take all this wonderful data and help resolve some of the resource issues. Did I hear that correctly? I just want clarity on that.
What you heard me say is that this data will help us and help the districts allocate the resources they have more appropriately.
Okay. Thank you for that clarity, and that's sort of along the same line. So, having said all that, that's great to say. How and where are the people coming from to offset the resource issue it's good that you can look at the data and know that we have an issue. I think we know where our issues are today. We've got hospitals closing, recommended to be closed. People are upset. I'm not clear, and I'm not saying I don't believe you, because that's not it. I know technology. I know the value of having such data. I think it's good. I don't want to take away from that. I think that this was put in place, and it was a good thing to go in place. It's always this time issue, but what people want to know for their $11 million worth, if that's the price tag on it, how are we going to fix the problem? It's great to know the data. What are you going to do with it?
The way I answered your question first was that to help the resources that we have be allocated appropriately. And
Not to interrupt then, just quickly on that.
Yeah.
Does that mean you're going to send Dr. A from Halifax to Glace Bay to do surgery?
I think it's premature to say that.
Okay.
I think what it does is it gives the information that the surgical care network, for example, can have that kind of dialogue to see what's appropriate.
Okay.
It opens up the opportunity. In terms of resources and where the people are going to come from, we're always going to have parameters on what our resources are.
And this comes around again to what I was saying about districts all doing their own thing, not a consistent application. Procurement was just one example. It's the whole thing. We're one province, we're less than 1 million people. How hard can that be? You know, it's incredible to know how hard that can be, but one of the problems I understand, what is it, 425,000 now live in the HRM or something, almost half, and more than that, again, travel in here every day. I understand all those demographic issues,
Yeah.
but the people are looking for an answer to how good the system will be. I think the system is going to provide something valuable. It's what we do with the valuable tool and information gained from that will be the real benefit. I think that's fair to say.
I think that is fair to say.
Okay.
A system, you can have a bunch of information. If you don't do anything with that information, its value is lessened.
So I guess on behalf of my constituents and everyone in Nova Scotia, I guess, my message today is carrying that there's the piece that's really key when you're out talking to, you know, the folks at Tim Hortons or on the street or in your office. This is what they care about. They don't understand way up here, nor most of the time am I getting, they don't care about way up here. They want to know when it affects them. Why this is when we are getting our calls and our questions. Why is this so hard? You know, because they don't understand all of this above. And that's, you know, I appreciate that. And your answers on, you know, management earlier, you know, you spoke about the clarity of who you all are by way of profession. And I think that that's important, because I'm going to take the answer to this back. And I'm going to show it to the people who are asking that they actually do have people that are qualified to be in those seats making those decisions, helping with the overall system management. And, you know, will surely to God, those decisions will be made based on experience and you know, the right values. So I want to move quickly to something you said here in your opening comments, page 15. This is a great concern for me as well, and I'll give you an example of why. We will maintain a confidential record. Are you telling me now that you're not maintaining a confidential record? Could I clarify that? And of who has access to patients' information?
I guess what I would say to you, and again, I'll ask Ms. Vicker to correct me if I'm wrong, is that we haven't, because there hasn't been a provincial registry before, the province has had nothing to do with the wait list that we're sitting in, for example, physicians' offices. And so that was to the physician and to the district to keep those records confidential. We are now going to have access to information, and it will be held confidentially.
Okay, maybe on the technical side of it, then I'll go to Ms. McVicker for a question. And again, around this, so it seems to me at this point in time, and correct me if I'm wrong, please, it seems to me at this point in time there are issues with the security of the system, who can access it and who cannot, and get information about patient records, whether they're surgical or otherwise.
Are we speaking in terms of the health care system in general, or
We are indeed, yes.
the patient access registry?
Patient access registry.
Well, I can speak, first of all, speaking broadly, every time we do any kind of an IT project, you start with a privacy impact assessment. That is standard practice for the government.
Okay. Yep.
And that we did that for this project. And we're actually in the process now of augmenting it, because there's a difference between implementing a system and having it being operational. And now that we have a better understanding of how it's being used, we're augmenting the impact assessment to reflect the users. What we're doing for the patient access registry is having a very strict access to it in terms of who can access it. And right now it's really just the access managers and the registry manager, and I believe one scheduling clerk and an IT person in the district. And all of those individuals have signed confidentiality clauses as part of as part of their profession and professional activities in the district level and at the Department of Health.
What would happen if those were broke? And I'll give you this example, and you can give me your thoughts on it. And I don't want to take a lot of time, but I am aware a family member has a son who's involved in an accident, goes to the hospital. Lo and behold, another family member works in the hospital as a ward clerk. Before the doctor even gives an assessment to the mother and the father of the condition of the son, the ward clerk's in the hallway spilling it all because she has access to the records. So you can see my concern with regards to confidentiality and records. One, it's okay to say that we're going to sign a confidentiality record. I think that that's pertinent, that's standard practice. But more importantly, why or how could this person have access to this system at certain levels? And again, the technology is a wonderful thing, and it's nice to be on the leading edge, not the bleeding edge. Where are we? Are we in a place where we can't control our technology?
We absolutely are able to track. There's a software, there's auditing capability in the system that tracks every person who's looked in there and what they've looked at.
How often is that monitored? Monthly, weekly, yearly?
That is the responsibility of the district privacy officers.
Okay. Here we are again back to the district. Okay, so everything keeps coming back to a district, or again, I don't mean to harp on this, guys, I really don't, and I don't want you to take it in a personal way. It's not meant that way. It's just a systematic thing that does not work. There's too many inconsistencies when you break things down to district and you pass the responsibility on to someone else. Again, it comes back to the overseer, and that's why I asked the question about monitoring. You're the more technical, capable person here from what I understand, who's been part of this implementation. So my question is, who's going to monitor? But there's a belief, at least in my opinion, that ward clerks probably shouldn't have any access to a chart unless it's maybe page 1 of 5. You know, there's got to be these levels. How defined are we?
Well, we define access to any system based on the person's role in the healthcare system. And in the case of a system like the Patient Access Registry or operating room information system, where all the data comes from in the first place, it would be on what your role is. And as I understand, ward clerks are responsible for entering, for example, post-operative information into a system. So they would therefore need to have access to the system for the duration of the time that they enter that information and for the scope of the information that they enter for that particular patient. Can they go search the system for every single report that's in there? No.
Sure. But they can see and have access to every little thing that's in that chart over the course of my lifetime if it's all in there. So if there was something personal there, and if there's something personal in this, all right, if I had something happen to me years ago that I wouldn't even want my wife to know, just as an example, yet this come out through this system. We know right now in the secure system, by way of the old papered chart, you know, that's not possible because numbers of levels of people cannot pull that up. Only they can pull up, you know, the current, I'm in the hospital, I'm being charted, whatever. So a lot of, you know, I have family members who are expressing this as a great concern, and they're worried about it because we have a confidentiality law in this province, and that's being broken every time that this door is open, so to speak. Miss English, you wanted to?
I think it has to be recognized that there are members of a healthcare team, and that members of that healthcare team don't only include the providers, the nurses, the doctors, but they also include people like ward clerks and booking clerks. They have a job to do, and you wouldn't want the doctors or the nurses to have to spend their time doing the clerical pieces of work that others are better trained to do and that the nurses and doctors are doing there. So I think we have to acknowledge that they are members of the team. They, as Lindsay indicated, there are parameters around what the booking clerk can get into and what report she can do. She only has a piece of it, for example. So we have to acknowledge that others are part of the team and need to be part of the team for efficiency. The district health authorities who are responsible for the delivery of care by the Act, they also have HR policies and confidentiality policies. I've spent over 30 years in the healthcare system, and I know and have been aware of people who have been terminated because of breach of confidentiality, because somebody picked up a phone and said, I understand a baby's born, when they wouldn't have known that if they hadn't worked in the hospital.
Yeah.
People lose their jobs when they have a breach of confidentiality.
So just for clarity, Ms. English, then, the proper channel is to follow through with that HR director, et cetera, whatever.
Absolutely.
Enforce that to the limit without any issues. That's what you would recommend as per normal and any other kind of employment.
That's right.
Where such laws would be
There are
broken.
policies there to be put in place. If people are aware of breach of confidentiality, the people in the districts need to be made aware of that so that the appropriate action can be taken.
Is there any consideration being given in this system, and I'm talking about family and family here, about family not having access? Let's say Susie's the ward clerk and, her sister Joan is the patient. Should Susie have access to the patient records?
Absolutely not, unless the patient gave explicit written consent for her or him to
So
view
is that something, Ms. McVicker, then that we would be looking at by way of policy to go in place if it doesn't already exist? Because this is the example that I'm using. This is real. And so put yourself in this lady's position, this family, the position that they're in, just having everything spilled. And, who is the ward clerk to tell me about my son's issues that are severe from a motor vehicle accident, and I haven't even seen the specialist or the doctor yet? Why does this happen? How can this happen? So you can see where I'm coming from with this. And it's all a patient record thing, regardless of it's in ER, surgery wait time, what you're doing, you know what I mean? This is all very relevant in my opinion.
Yeah, and that's a very serious situation, and I can say those policies already exist. To me,
They
that sounds
are,
like a
in your
breach. I mean,
opinion, these are all in place now?
at the district level, and you would follow up with that individual district privacy officer to discuss.
With regards to family versus family?
Absolutely.
They would be there. Okay, that's good to know. I appreciate that very much. Thank you for being here and answering my questions. I'm going to hand this over to Mr. D'Entremont, who is anxiously waiting to ask a few questions.
Mr. D'Entremont, you have a minute and a half.
Seems to me this happened last time I came to public accounts and I let him have my 10 minutes. So all I can say is I'm very glad to see you here today. This is a wonderful project. I think it's taken a little longer than I would have anticipated when we first got the dollars available for it. I think I will save my comments on whether it's a good system or a bad system when it does get implemented in 2011 and we start to see some of these pieces of information on wait time. But again, it's good to see you here, and we'll be watching it closely.
Thank you very much, Mr. D'Entremont. And with that, we'll turn it over to the NDP, just a little bit ahead of schedule. And Mr. Pereira, you have the floor for 13 minutes.
Thank you very much, Ms. Whalen. I do appreciate your being here, and it sounds like a great project in the works. We're looking at it somewhere in the middle from the sounds of it. And I do want to follow up on a question that Mr. Porter was asking about confidentiality. I heard you say that access to this information will be restricted to the access manager, to the registry manager, and on a need-to-know basis to the people who are actually serving the patient. Is that a fairly standard practice? I know you said a number of provinces were implementing it. Does that conform with best practices as far as you know, in terms of access to information?
Absolutely, and our priority is adhering to privacy policy and being consistent in Nova Scotia with what our privacy policies are and with other systems that are on the ground.
And the relationship with the doctor and patient and the access to documents relating to patients, those conventions have been developed over a couple of 100 years, and are those practices still being followed in terms of who gets access to a patient's record? Does the registry change anything in that regard?
No, doctors are accessing all the information they would have ever had access to in a paper form in their own office, just via reports that are provided to them by the access manager.
So essentially what we're looking at then is a larger system that's being created that would allow healthcare centers and healthcare providers to share some information to reduce wait times. Is that?
Yes.
So let me just ask in general, question was asked earlier about what we're not doing. And I guess my question is, where do you see the system going down the road? What are we trying to accomplish? What are we trying to build here? Ms. English?
Okay. This system has begun, and we've called it Patient Access Registry for Nova Scotia for a reason. Right now, it's being used for surgical wait times, and that's been the experience in New Brunswick, and that was our need. There is potential for this registry system to be used in other areas as well beyond surgery. We want to make sure that we have the surgery bit down pat before we move into anything else and assess it and evaluate it. But there is potential to use a system that goes beyond surgery. So that's potential. We have to evaluate to see if that's where we're going to go. Again, it's the use of a single source of truth to be able to make decisions upon. talking about the evolution of the surgical care network and how the surgical care network will use this information to have discussions and make decisions on how surgery evolves in Nova Scotia, how best practices can be used. And those are some of the pieces. So it's the potential to go beyond surgery, and it's making sure that, you know, to have a surgical network addresses some of the issues that the honourable member here talked about in terms of district by district. It gives that potential to look at things provincially and how things are looking, and not just within the single scope of a district health authority.
And very soon, I understand from earlier hearings we had that this will be married into the larger electronic health record system as well, and there are a number of units entering the system, and they are being merged and reconciled as we speak.
That's right. That's right. It's compatible with exactly where it stands in the queue to go as part of the EHR. I'm not 100% certain, but when that time comes, the compatibility is there for it to be compatible with the electronic health care record.
So at the moment, there are these various systems that we're trying to bring together so that there would be some consistency and some coherence, so that these various units would talk to each other.
That's right. And don't forget, with the patient access registry system, it is not a patient-specific system, it's a database. Whereas a lot of the electronic healthcare record is going to be specific to a patient. So it's a little bit different in terms of its purpose. It's a database. When we talk about the electronic health record, it's going to talk about people's visits to emergency and their diagnostic imaging, and it's very much more patient centric. This is a database that covers a lot of things, but it is compatible with the electronic healthcare record.
Now, as I understand it, the main priority is to establish a real-time triage system where you're tracking the system, you see where the gaps are, where the services are available, who's been waiting in what section, and at this stage it's more of a monitoring, trying to get a better sense of how things are working right across the system.
That's correct.
And the system as it stands, the patient access registry system, is live for people who are in fact working within the system, and that there's a validation of data, but there's a lot of data being used at the moment in establishing those priorities.
It is live, yes. Yeah.
And that system, along with the electronic health system, is being sequenced in as they get validated, as the data reaches the threshold that you're setting for standards for use of that data, that those systems will come in as they are validated.
Yes, I don't want to get too confused between the electronic health record and the patient access registry system. They are two different things, but as the information is being validated through the patient access registry system, it is being used in some districts now, and it will continue to be used, and by January it is the source of truth.
So this is part of what you would consider ordinary due diligence, to validate the data, to monitor it, to make sure it's accurate, because people's lives are at stake?
Absolutely. If we want to have certainty of the data that we're using for decisions, everybody involved needs to make sure that it is good data, that it is clean data, that it is complete data. Only then will people have confidence to be able to use it for decision making.
Now, I know that some of this, I had a note, but I've lost it here, but a number of provinces are using a similar system. What kind of information sharing is going on? Are you comparing it with other provinces, and what kind of learning is going on there?
At this point, I'll start the question, and then Ms. Vicker can carry on. There are a number of sources of information that we get information from across the country. So CIHI, which is this Canadian Institute for Health Information, is one of the areas that gathers up information from across the provinces and does reports. There are a number of sharing mechanisms from across the province, and then how we use that information. I think our relationship with New Brunswick has been the most intimate on this one because of the use of the system. I think that the opportunity within Atlantic Canada to be sharing information more fully and working together on a lot of things, be it networks or whatever, is there. And again, it's with that information that's going to give us the bridge to be able to do more work. Anything else that you would add to that, Lindsay? No.
Thank you very much. And I recall from earlier discussions we've had about electronic health records, and I think it was Ontario that had terrific problems in their implementation. And did you look at the experience in Ontario and the problems they had in setting up this system?
I guess what you're referring to is the e-health issues in Ontario. We have not experienced the same kind of issues that they have in Ontario from a governance point of view, from an accountability point of view. I know the AG and internal audit has been involved with some of the work that we've been doing, and Nova Scotia has done this work very well. In terms of the province that we liaised most closely with for PARNS in particular, it has been New Brunswick. But I think it's true that as we look at the electronic health record, Sandra Cascadden, who's our Chief Information Officer, has a wide network of colleagues and is very involved in the pan-Canadian kind of work that's going on in this area. And so we're learning from all the provinces in the bigger scope of things all the time. There's a lot of communication at that level, and thankfully we are not in the same position Ontario was in the governance of their system.
And I suppose because we've learned from that experience, we're considered one of the most successful projects in implementation. I know when we compared our Auditor General's report on the electronic health records to the Ontario reports in some of the other provinces, we actually came out looking pretty good.
This is done very well in Nova Scotia.
And I know Ms. McVicker alluded to this earlier in talking about New Brunswick, but one of the benefits of that process was that we were able to build on that experience. And I'm looking at things she said about the operating room info system, which was integrated into this system, the type of stakeholder engagement that went into the development of the process itself. And so in a way, Nova Scotia has learned a lot from that experience, and I assume now people are learning from Nova Scotia. Ms. McVicker?
Ms. McVicker.
Absolutely, yes. You're absolutely right. We were able to take some materials, tools, practices, lessons learned, best practices from New Brunswick, and we do interact on a regular basis with all the provinces at a Kai-High working group around wait time issues to ensure that while we're looking for standardization and consistency in Nova Scotia, we're also looking outside of Nova Scotia for best practices and standardization between the provinces as well.
Well, I think I'm done with my questions, Madam Chair. I started early, I'll end early. And
that's good. No other questions from the NDP Caucus? Then thank you very much. It's still a good time for us to wrap up. I wonder if you'd like to have any final just closing statement at all, Ms. English. I'll turn it over to you.
I think that it's fair to say that we're very excited about the opportunity, excited might be a strong word. We're enthusiastic about the opportunities that this information system that we have not had before, that districts have not had before, gives them, and it gives them a chance to plan and allocate resources appropriately, and gives us the opportunity as a province to be able to monitor, evaluate, and hold accountable, which is our role within the District Health Authorities Act. This is a new opportunity. I think that I'd like to, for the record, compliment all the stakeholders and all the people within the healthcare system that we had working on this very complicated project, and the work that they did in the changing of their practice to be able to come to where we are today. They've done a wonderful job, and the surgical care network on a go-forward basis, again, is such a place for potential to be able to look at how we do things across the province in a less fragmented way. So this is a building block system. It's like, we get into a car and we turn on a car and we say, thank goodness it turned on today, and we're not thinking too much about all the work that went into the engine. Well, this is the part of the engine that we're building to be able to make decisions on, and it's a very important part of our information infrastructure. Thank you very much for all your questions today. They were helpful to us in our go forward as well.
Well, thank you very much, Ms. English, and we'll also be watching and hopefully have you back as it unfolds further, because as I said in the beginning, we tend to look after the fact to see, you know, again, how things are being maintained and the budgets are being spent. So we'll hopefully have you back again in a year or two to see how things are going, but thank you very much. There was one request for information on the budget that was following up on one of my questions, whether or not the budget was overspent or just where we were at. And if you could, at the same time, provide information on the budget for this year on the maintenance and operating of the system. We didn't get into this year's budget, so if you could provide that for all members of the committee, that would be something I'm requesting as well. And I think that there were a couple of things that, Ms. English, you said that you would provide, that one had to do with the percentage that were not on the list now, the ones that, the 27% that would no longer needed surgeries. I think you said that you would give a breakdown on, you know, what the reasons were for those people coming off the list. Yeah, I'm not sure that Mr. Porter asked for that, but it came out of the discussion. Yeah. So. Yeah, that would be great. And again, we appreciate your being here. On the committee business, you'll notice there was a correspondence from the Department of Finance that was answering some questions we had a few weeks ago on the October 13th meeting. And we have received notice from the Auditor General so that you can schedule in for November 17th an in-camera meeting on their fall report. And again, on the 24th, we'll have a public meeting also related to the Auditor General's report. And next week, we have the Gaming Corporation coming, which we're pleased to see with the Support for Sport being the program that we are going to principally look at. So with that, I would ask for a motion to adjourn. Thank you very much, and we are adjourned.